hand it over. Nope, Lisa's shaking her head. I think, yeah, Dave did say, you know, it is early for some people, but if you guys can share your video, obviously we're in the virtual space, we don't get to see each other, but being able to see each other even in a little bit like this, you know, we can all be jealous of Giorgio and his Florence background. You know, it's a little different than my banjo background, but whatever, you know. But just to get to see each other, I'm really appreciative of everyone that does come to these things, and I hope, you know, we've got a plan for virtuals for the future, but I hope at some point we'll all be able to get together and see each other in face to face. So with that, I will pass it over to Giorgio, who's going to do, like I said, from HL7 Europe, and he's going to talk to us about the international patient summary and some of the, you know, harmonization that's going on. So Giorgio, I pass it over to you. You can take the ball.
Thank you so much. Let me see. I hope that you can see my screen now and you can hear me.
Yep.
Okay, let me. Okay, so I'm Giorgio Cangioli. I'm a consultant. I am involved through HL7 Europe in several European cross-border projects and have been, together with Rob Hausman, the facilitator of the IPS project. I'm also involved in the ISO IPS project and the AG project team. The intent of this session is to try to describe what are the main similarities and differences in the IPS and the C-CDA template, and try to share with you and discuss with you what could be the possible harmonization approach that could be followed in order to find a sort of common parent for the two templates. And for doing that, let me give a brief introduction to the IPS. I will not spend a lot of time on that, but I think it's important to understand that the IPS is not a European standard, it's a universal template. And when the IPS has been designed, we take in consideration the C-CDA, the HEPCC, the European Cross-Border Patient Summary, and we try to learn from all these different experiences and to try to take the best from each of them. And in the design of the template, we try also to understand how the representation of that content in the file could be done. In fact, we have for the IPS, the CDA representation and the file representation. The International Patient Summary is, as a patient summary, is a snapshot in time of the healthcare information. It is not expected to be used for representing a full EHR. The International highlight the fact that the solution should be applicable globally. And when it's been designed, is not a general purpose patient summary, but is being designed having in mind the unscheduled care. And also is in bracket cross-border because some of the requirement comes from the fact that we should like to allow the adoption of this patient summary also for exchanging information cross-border or cross-domain. But the intent is to have this as a baseline also usable for other cases. When the IPS has been designed, the principle for designing is to consider a minimal and non-exhaustive data set. Minimum means that we are not pretending to cover all the possible situations, but try only to identify a core set of data that could be used by different care professionals in different situations. With the intent that if you need to have more, you can add based on your needs. As told, it is specialty agnostic and condition independent, means that is a starting set that is not being designed for a specific condition of the patient or for a specific specialist, but to be used in different situations for different purposes. So with this in mind, it's clear that the IPS and the C-CDA are similar, but are not exactly the same. And this difference is even more evident when you think that some of the C-CDA template are used in different kind of documents. So I have a wider scope rather than the template used by the IPS. And this difference is the origin also of some, as I told, differences between the two. But what we would like to focus today is on the look to the similarity and try to see how we can try to harmonize and find a sort of common, maybe, denominator in order to have in future, the CDA and the IPS as derived from a common template. This has been done starting from two topic, the allergy and the problem list, by relying on the activity that has been started some time ago about the collaborative CDA template. And this work rely on the great work that has been done by Lisa and others on the comparison between the C-CDA and the IPS for problem and allergy. This specific presentation has used these two versions of the C-CDA and the IPS for comparing the template. So let's start from the problem. If we try to merge the two templates, the first thing that we can see is that both IPS and C-CDA use the same pattern with a concern ART, problem observation, the same pattern that I use also for other template, and problem status. The difference is that, for example, the C-CDA supposed to recommend to you to have the author at the level of concern act, at the level of problem observation, while the IPS do not request to define a specific author, to specify explicitly the author. The other difference is that, for example, both have the problem status, but the IPS include the certainty observation and the severity, while the C-CDA provide template for conveying the age, information about the prognosis, or the priority preferences. It's clear that for the IPS, this template is used only for the problem list, while the problem observation is used in different type of concern for the disease, for example, the hospital also discharge diagnosis, the encountered diagnosis, or other type of observation. It's clear that information like prognosis may be relevant in these cases, maybe less in the IPS per se. If we look to the part of allergy, the structure is similar. There are the same consideration about the author participation recommended in the C-CDA. The suggested pattern for describing the agent is the same. The only difference is that the IPS suggests to have the agent in the agent participant, but it could be omitted if the a diagnosis about the allergy is provided, like a code that say intolerance to latex. In that case, the agent could be omitted to take in consideration some countries that prefer to have this kind of representation instead of having separate code for the agent. And we have similar structure for allergy status, criticality, and reaction. The only thing that there is in addition to the IPS is a certainty status also for the allergy and or intolerance observation. The C-CDA include this severity template, but it should not, and the severity is, as it happened for the IPS, is under the as part of the reaction. So it's the severity of reaction and the criticality of the observation. In addition, the C-CDA in the reaction include medication activity and a procedure activity that is not explicit in the IPS, but this is still a consequence of the fact that the reaction is used not only for the allergy, but also for in other contexts. And so it's reasonable that you have also this other information that are not present in the IPS. So this for an high-level overview of the template. But if we go more in detail and we try to analyze each template, because when I say that the both has a reaction or both has a severity, it doesn't mean that use exactly the same template. So if we go more in detail, and what has been done is to try to compare the two templates and to merge in a single template the IPS and the C-CDA. This has been done in ART-DECOR, and this is the way ART-DECOR represents the template. So since most of you, I suppose, are more used about this kind of representation rather than this representation, let me spend a few minutes in order to facilitate the understand the comprehension of this kind of representation of the template. So the ART-DECOR, that is the tool that is used here, use this tabular representation. You can find here the link if you want to have more detail, but the important thing is that for each element or attribute, you have the cardinality, the conformity label, and a description. And what I try to do is to make explicit what the C-CDA say and what the IPS say for each of these elements. And this is what you'll see in the template that I will show you later on. So the only thing that you need to consider is that the in the table, in the conformity, you will find some label like F, M, or R. I think that the meaning of M mandatory is quite straightforward. The only difference that sometimes is confusing is when you have a conformance required and the cardinality 0, 1. This stand for, this is used to say like a recommended or R2 in IHE, mean that if you have it, you should include it. Otherwise, you can, if you have this information, you should include it. Otherwise, you can omit the element. So let's, the other difference in the ART-DECOR that I need to mention is that ART-DECOR, based on the HL7 template, exchange format allow for different binding, not only for code with extension, with no extension, without and with extension, sorry, but allow some more flexibility, allowing for preferred binding strength or example binding strength, as we have for the fire. So let's try to go in more in detail and see, for example, the problem concern at. Let me move to the other screen. And if you go, you should have the link in the conference page. But if you go to the in the ART-DECOR, in that site, you can see that, for example, the problem act substantially has the similar structure as described before. The only difference is that you have, for example, the ID that is not required in the IPS, instead is 1 star in the C-CDA. This choice was made because in many cases the ID was not actually used, was in several cases fake ID were put there and not actually used, so we decided not to make this required. The status code has the same meaning in both cases. If you look to the description, the only difference is that is that the IPS allow for active and complete, while the C-CDA allow for wider flexibility, meaning that allow for substandard or complete or aborted, that we didn't feel was usable for problem listing the IPS for a minimal set of data. And the similar thing is happened also for the Allergy Concern Act. And so one of the possibility in that case might be that of maybe or to leave unconstrained the harmonized template and allow for restriction of the IPS, or to use an extensible value set with a minimum, as a minimum value set based on the IPS value set. If we look to the effective time, the meaning of the effective time are the same, how they are dealt. The author is not present, as told before, in the IPS. Even obviously it's allowed to have it, because it is an open template. What is interesting, and I would like to share with you, is how the relationship between the act and the subordinated observation is realized. I put here 2 examples that I get from some European cross-border services, and these represent 2 typical cases that I saw in the main cases. One in which there is the effective time in the act that is exactly the same, copied from the other one, and the other case in which we have the act new flavor and with the data that are in the actual data that are only in the observation. These this means that the people that are building this CDA actually do not have the concept of concern in their system, mean that they have this observation and then create the concern act ex post in order to fulfill the template, rather than managing the concept of concern act and giving the right information. I don't know if it is the same. This is what I saw in the European cross-border services in the 99% of the cases. That's the reason why maybe the possibility of maybe simplifying and making more clear the structure, having maybe only one observation in the problem list, might be helpful. And really, I would like also to understand from you if it is the same situation. That's the reason why when we design the IPS template, actually we try to map the problem status observation in the clinical status, the severity, obviously in the severity, and the certainty in the verification status. And it's clear that the status code of the concerned act and the effective time have a non-direct mapping in the FHIR, The problem is that in many cases, the problem status observation is not filled and there is only the status code. So in that case, we should understand how this should be mapped into the fire resource when you have the fire representation. The problem might be even more complex if we have a real concept wrapper with more observation. I confess I never seen that in the European patient summaries, but in that case, the how to map it could be even more challenging. So, if we consider the problem observation, sorry, let me move back to the, sorry. If we look in more detail to the problem observation, please feel free to stop me and ask me question. I proceed if I don't hear any specific question. So if you look to the observation, beside the fact that the ID that is mandatory in one case and non-mandatory in the other one, the first difference that we can notice is that the code is limited in the IPS to a single code problem, because the intent is just to list the possible problem, like the problem item list that we have in FHIR. While in the C-CDA, the number you have a normed code that should be used, and if it is used, you have it in the translation the long code. In the CDA, in the IPS CDA, it is limited to a single code, but is extensible for the FHIR IG. I believe that, this is also come from the fact that the problem observation in the IPS is used only in the problem list with the purpose of listing the problem. In the other case, the template is used in other contexts, like in family history or indication, constraint, and so it's clear that you may need to have the need of having more different type of observation that you may want to describe in a more granular way. The question might be, if for the problem, what is the minimum set of concepts that you should consider, or if you need a separate template, for example, for managing the family history observation, and so I think these are things that need to be discussed in order to select also a common value set for the observation code. Let me pass directly to the other point, is that the observation value. What is used in the, what is written in the CDA is that, for example, a negation in is true coupled with a specific code is used for expressing a non-known condition. This is the difference that we have with the IPS. In the IPS, the expression of non-absence or non-available information is represented by using explicit code, and this is our code that are passed through the observation value. And a similar approach is used also for the allergy observation. So in that case, it's clear that we should discuss and understand a common pattern in order to represent this kind of non-absent situation. The choice that has been done in the IPS was in order to have a more easy representation in FIRE, in which we have the absence of information in the by using an explicit code as well. In the IPS, we have no is not addressed the fact of a negation of a specific problem, because it was not addressed in the initial requirement. Very recently, last week, we have been asked to consider also this situation for example, in case of rare diseases, in which to explicitly exclude specific diagnosis. It's clear that in that case, it's not practical to have explicit code for negating each possible diagnosis. We obviously, in that case, one of the discussion was to try to leverage on the verification status by using the refuted concept, but I think that we need to further analyze and understand. So these are the main thing that we can see. You can analyze and see each single differences in the template that you can find. You should have the link, so you can go more in detail and see for each element what are the differences and the similarities. I don't know if, before proceeding with the allergy, if you have any question, and
Giorgio, this is Lisa. Thank you very much for that presentation. It was incredibly interesting, and I have really enjoyed watching this work come together. A tremendous amount of comparison and learning has come from this. I was wondering about one thing that I noticed, I think, as I was seeing in ART-DECOR. Do you guys only require the root part of the template to be asserted and not require the version part to be asserted, or have you taken a different approach to versioning your templates?
Sorry, I mean that in ART-DECOR you can versioning your template, and is not here explicit, but I can show you, for example, for the international patient summary. So indeed, you need to be a little bit, okay. If you see, for example, here, we need to be a little bit patient. Yeah. If you see here, you should have here the history, and you should be able to see, sorry. I mean that you can select and see select the different version, and see select the version and see what are the specifications for a specific version label. And this is what you can have it there.
Yes. But when you assert the template in your template, the template has a requirement to assert the template.
You can do both. You can do
I noticed
both.
just the root was being asserted and not the version, and I was wondering if this was an approach explicitly taken to give you more dynamic flexibility to version your templates over time.
Yeah, I mean that for the time being, let's say the reference is dynamic, but you can specify a specific version of a specific template when you make a reference inside your template, or you can say this template dynamically. So you can do both.
Yeah, I think that's an interesting, we're thinking about what will happen when we move consolidated CDA forward, and people have talked about the possibility of having templates be able to version and have the specification be able to more dynamically absorb that, and I thought that was a clever approach where you're just specifying the root and not within the template specifying the version. It might give some greater flexibility. Thank you.
Okay.
Georgia, this is Gay. Back when we were looking at the differences in the problem representation, you said even for asserting that a specific condition does not exist, you're not using negation indicator, and you're using coded terms for that instead. Are you able to find all of the codes you need for every possible condition to assert that it is not?
I mean that, as I told, we are, for the time being, we use explicit code for saying non-absent problem or non-absent allergies. In that case, we use explicit code. We are not addressing, we have not addressed explicitly the negation of a single assertion.
Oh, I thought I saw that. Sorry about
Okay.
that.
We are not, we are, let's say, what we are discussing now is that since we have received that request to be able to negate specific diagnoses for rare diseases, we are discussing, but obviously we need to have the input also from the patient care and other, to use the certainty and to use the refuted to say, I negate that you have that.
I see. Okay.
Instead of the, but we have just started this kind of discussion, and we really would like to learn from the community.
Okay. Yeah, I know that's what they do in fire. I don't know that we have not done it that way in in C-CDA, but certainly something could be talked about.
We're the only ones, though, Gay. Like,
Right.
if you take a big survey around and look at what's been done in other places,
Yeah, yeah.
unfortunately,
No, I'm not
we're
saying
the
what we
odd,
did
we're the
was
odd man
necessarily the
out.
best way.
Yeah.
Mhm. We were
Giorgio,
just
have
following
you
the rim.
I know. Have you considered what would happen if that concern wrapper weren't utilized in the problem section? Did you think at all about just using the straight up problem observation entry template rather than requiring that concern, the more complicated structure?
I mean that I believe this should be the right way to go in order to make a more straightforward mapping with also the fire representation. What we need to be careful is that there are a lot of existing implementation, and so even if they are not managing the concern art in the same proper way, this is how it is implemented currently. So we need to understand what is the impact on the existing implementation. But I believe that this is to give the both option be the right way to go.
Well, on that point, Giorgio, so I agree with what you said, which is generally I've never seen an ACT concern with multiple problem observations, even though certainly it's possible and laid out that way, that it could be that way in the standard. You mentioned kind of limiting it to one problem observation for the ACT concern. Does that substantially ease the mapping issues to fire?
No, I mean that if we have in reality we have usually one, okay, one act and one observation. The problem is let me show you how do you interpret. I mean that there are different ways in which people. Let me show in this slide. Okay, if people feel the problem status, the severity and the certainty, then there is a straightforward mapping with the 3 element in fire. But as I told, many people do not fill the problem status. They have the status code. So should we use the concept that status code for filling the verification, the clinical status is the right way to represent? So or we impose to represent these 3 information with a separate observation as we have here, or to have the constant hat, I think, give some uncertainty on the how to interpret the different element. So I think that to have one single, just as direct observation as entry could make easier the mapping between the problem list and the equivalent fire representation. But this is my impression, so I would like also to hear from you, to learn from you.
Yeah, I know when I've been doing, excuse me, sorry, C-CDA to fire mappings, that's one of the problems with the concern observation, and it occurs, that pattern that occurs in C-CDA of multiple observations to a problem. So restricting that obviously would make it simpler.
Yeah.
It's an interesting. Does anyone else have any questions?
I'm wondering if it's interesting enough. We've talked about this for so many years, and this issue has given us trouble for so many years, and where we are trying to understand if the implementer community would want to move forward with things or take any action as a result of thinking about this. And I do think this is the place that if implementers were to indicate that going forward, it would make things better to get rid of this wrinkle of the Concern Act around problem observations and narrow down. I mean, while there is still a point in time where it seems like no one in the wild is putting multiple problem observations inside that concern, maybe this would be the time to nip that in the bud and put ourselves in a position where mapping to fire became more straightforward.
Well, the one thing Giorgio said, Lisa, was just the that you still have that status issue, which is actually a really big issue. That back in the development of C-CDA 2.1, originally that status observation within the problem observation was deprecated. Now it's come back for it, but the idea was that the ACT concern became the definitive way through that status code to determine whether the problem was active or not. And I mean, yeah, no, it's complex to think about what happens if you change that.
But that active, Giorgio, put up the slide that you have that has the fire condition structure that shows the different statuses that are available, if you could please. The problem status, where the 2 is there, that is the definitive clinical status in the CDA way. So that maps to clinical status and condition. And I'm not sure which of the, what field in this fire condition structure would I'm going to call it the machine status, the status code, which is your machine status up there underneath the concern. What does that map to in fire?
Well, so in that circumstance, we see the vast majority of problem observations that we see don't have a problem clinical status in there. So you have to be mapping that ACT concern over to some way into the fire, or you're just going to put everything as unknown, which would be very not useful.
You would have to do what, John? Say that again.
Well, the status code, I've got, I don't remember exactly because I haven't been the person working on this at our company, but the status code to the clinical status has to have some sort of, relationship when you don't have a problem status. Otherwise, I mean, I guess you can just leave that blank all the time for it, but there has to be some way of differentiating active versus resolved problems.
Well, the effective time is how you.
Oh, the effective time. Sorry, actually, the effective time is how you do that. Sorry, you're right, Lisa.
Yeah, the effective time is how you figure that out. I'm not really sure what happens with status code underneath the Concern Act.
Yeah, no, you're right. I don't know actually what happens with the status code, but the effective time at the act concern levels has a relationship there. I mean, the reason why I'm mentioning that you go up to the act concern level is because you don't always have that problem status, because at one point it was being discouraged.
So do you think that we're just going to have to live with this problem forever, John, or do you see a path forward?
If you simplified it the way that's being mentioned, if you simplified it to just the problem observation, you have to then think about making the problem status a required element. So it's a relatively big change. I'm not saying it's not a good change. It's just I'm not sure. Yeah, that's a big change.
Well, one thought that I had is what if we, in the problem list, what if we permitted and explicitly said that you may have a problem observation template, and that problem observation template would have a required problem status, as you said, to make it so that if you did decide to start converting over, and then implementers who are in a position for backwards capability, we would still leave the possibility that your problem section could have problem concern entries in it, but everybody who's ready to start moving over could have problem sections that only had problem observations in them. And that would give us a stepping stone and flexibility that people could begin and plan to start converting over, and then make that be a part of an internal roadmap of getting yourself to a place where you were more aligned and better positioned to convert to fire.
And Gay, do you have any kind of thoughts on that? I mean, you were obviously there a lot with original decisions or original thought and thinking around some of these things.
Oh, sorry, I was multitasking, but are you still talking about the concern?
Yeah. Yeah, I mean, Lisa suggested basically having optionality to drop the concern wrapper and just put problem observations, which would ease that fire conversion aspect of it.
I mean, I've never liked the concern personally. I thought it was, unnecessary, but it generated from back in the CCR days. And that was a requirement in CCR, and from the patient care had this, concept of concern, which they're not concerned about anymore. So, on the other hand, people have it, people have implemented it. I'm not sure anyone's going to go back and, code to take it away. And all kinds of funky things are done, as you know, in the wild with that, like in terms of time and status. I see C-CDAs in the wild that have, no time on the observation, nulls on all the entries within a concern, and the time only on the concern, and vice versa.
Yeah.
So, it's more than just.
It seems like we're trying to raise the bar on some of those to get rid of some of those problems, Gay. And I'm just wondering if this would be a time that if we made a better, clearer problem observation template, like a new version of the problem observation entry, or if you wanted to, you could call it something else. You could call it the condition template, which would be exactly like problem observation, only we would be clearer about requiring the clinical status in the problem status part, and then allow that template to be used and asserted in the problem section. and let implementers, I'm not saying take problem concern entries use away, but you would allow either, and then allow implementers to gradually and at the right time when they're ready, start just using the cleaner template.
Yeah, Brett just made a comment that I agree with. You know, because there's so many. There's like 5 billion or whatever it is now in a year, and 900,000 in a month that are sent, and
Yeah,
you know,
but
that
as
giving guidance.
as implementers, am I mute? Sorry.
Nope, you're there. I hear you.
I can speak for our implementation. We implement this really because in CDA documents, because the IG makes it a shell. I have seen no business rules that I'm aware of in all the years I've worked in on EHRs, where the provider will specifically say, I am concerned about this problem as a business rule. So the whole part about implemented a lot of times is because when it comes
Oh no, I know. It's totally because we required it.
on the
Now it's
in
there.
the IG as such.
Yeah, that's the thing. Is like,
And if it's relaxed to reflect true business rules and true clinical, use, that would be nice.
Yeah,
So Emma, the recommendation or just like as I threw it out there to say that in a problem section, if the way that problem section, it said you could use entries that conform to problem concern entry, or you could use entries that conform to problem observation. Would that help you or make things worse, be better or worse? Better?
If it's more flexible, it would probably be better.
yeah.
Because
No,
remember, the results used to be like that. Something used to be like that, where you can either use it in the organizer or outside of an organizer. We had that option at one time. I don't know if it was 1.1 that did it, or, it was something that you could have.
yeah, there's the same problem there, right?
Brett, I don't know if you can't take yourself off mute, but it says, I think we should make explicit statements about how we no longer recommend use but not restructure. What do you mean by but not restructure?
Can you hear me, Lisa?
Yep.
Yes, now
Okay.
I can.
Yeah, I mean, I think making it clear what parts of the concern are no longer used or not recommended for use. But I mean, I'm concerned that people built their parsing capabilities assuming that's going to be present. And you may be introducing a cost to the system that really doesn't add, people have been generating it this way for 10 years. And that the benefit of pulling it out at this stage is we're going to have folks who never upgrade to this, and it's going to create kind of a mix of implementation where I think it'd be better if we just said, hey, we've deprecated these parts of the concern, we know it's still sent, but we don't want folks to use it.
So you just carry like sort of dead XML, like dead leaves on a plant. Maybe we'd have to play out what that example would look like, and I definitely think that you would want to tighten the cardinality inside the existing template, even if you left it called a problem concern and you deadened the top act or outer act, but then you would want to tighten that to say you'd only ever find one problem observation inside that dead act wrapper.
Yeah, I mean, and you could just do that through, suggestions, recommendations, conventions. You could also just do it through loosening the conformance statements on the upper concern act, not removing the structure, but letting everything up there be optional aside from having an entry relationship to a problem observation.
And I mean, I'm happy. I mean, Lisa, surveying out to ask, eHealth Exchange folks in DD to say, and ask those kind of implementer community, how would they respond if we peeled this off? I don't, the idea of, to me, the lowest cost thing is to make it clear to not use it. And then if it's hard for me to understand the risk of kind of completely getting rid of it.
That's good suggestions. All right, super. We're trying to take some actions. So it sounds like the action is to maybe formulate, maybe an examples task force, we could formulate either 2 options or one most ideal option if the group comes to that, and then socialize it to see in the communities where these large volumes of CDA documents are being generated, do some sort of a survey to get feedback and to understand what would the issues be, and would implementers be interested in making a move like that or not. So the actions would be to tighten up the draft recommendation, and then do polling in a larger forum than just this IAT.
Sorry, Lisa, is that gonna, I mean, we want to assign someone to the action item. Are you going to take those 2 action items on, or?
Well, what we did last time, and the reason that we're reporting out at the end, is the CDA management group actually took on all of the action items, and in terms of monitoring and determining if they're getting done and making sure that the right people are working on them. So I think that if we document a new set of actions as a result of today's activities, we would probably do the same thing, where we would absorb them up into the CDA management group, and there sort of determine who needs to be working on what and how to allocate resources to get the actions completed.
Okay. All right. So we've got those 2 action items, and I would encourage everyone, I mean, to if you haven't, to take a look at the IPS. This has been to me, a very informative session. Thank you, Giorgio, for that, especially seeing the differences. For other projects, I have looked at the IPS, and I've never really, I haven't put it in context with C-CDA, so I haven't looked at the differences. And you highlighting, for problems and for allergies, the 2 differences is a really good. It's got me thinking about some other things I've been doing, so that's good.
Giorgio, one question on the IPS. Do you have examples of, like, fully populated IPS, XML, or?
I mean, that there is the example that is provided with the IPS IG.
Okay.
There's an example there you can download the package.
Lisa, I thought we had 2 beginners pinging me that we may have only had 1 action item. You mentioned one thing about examples task force, and then another. Like, what do you think we have for action items? Just 1? Or 2?
I think with the 2 are, first part is to solidify either a proposal in terms of, like, what would be the solution. Either it's like you could do A or you could do B, option 1, option 2, or if the examples task force comes up with a single proposal, something like that, but just to harden it up so that we would be explicit about what a possible change would be. And then the second, you can either say it's a second part or you can say it's a second action item. But the second thing was to poll a much larger community, like the Commonwealth Care Quality, Direct Trust is a large community of CDA exchangers, and find out from a much larger group rather than just this small representation of implementers, but a much larger group, find out what the impact would be and if there is any level of interest in addressing this, making a change.
Great. All right. I'm taking over screen control. We are at the top of the hour, so that's it's time for a 15-minute break.